Good evening, everyone. Welcome to tonight's webinar. My name is Dan Green. I'll be your host this evening. Given that tonight is a Tuesday, we will be doing cases from your case list. I'll try to pull those up as quickly as we can. Again, tonight is October 12th, 2021. I will ask for volunteers in just a second. I will also ask if you've been in the hot seat, let's say last night, Monday night, or for that matter, Sunday night this week, so the past 2 nights, please put your hand down so we can get other folks in the hot seat and try to give everybody who wants to be in the hot seat a chance to be there. So having said that, let's look for our first volunteer. Amanda, says yourself muted.
Hi, how are you?
I'm doing well. How are you?
I'm okay.
Good. So if I recall correctly, you're a generalist, is that right?
Correct.
Very good. See, I picked the most common, so anyway. So let's see here. Let me just pull up. Oh no, these are not alphabetical. There
I think
we
I'm
go.
partway down the list.
Yep, happened to find you anyway. So again, you said you're generalist, so we will start with a GYN case. Bunch of ectopics.
Yes.
Okay, give me 1 second here. So patient number 12 is a 29-year-old G3P2 whose 10 days status post a repeat C-section. She had fever, chills, myalgias, abdominal pain, postpartum endometritis. She received inpatient care, IV antibiotics, and went home in 2 days. So tell me, when you have a patient who's postpartum, how do you use the onset or timing of the appearance of the fever to help guide you in your diagnosis?
So generally when I have a patient with a postpartum fever, obviously I'll start with a detailed history and physical exam. When I do the history, the timing will help to sort of elucidate, to clarify the etiology of the fever. Generally, I follow the sort of like the little mnemonic we all learned in medical school: wind, water, wound, and then like wonder drug. So generally, if it presents early on, several within like the first day or two postpartum or post-surgery, usually it's wind, which would be like a pneumonia or an atelectasis. Subsequently, usually several days later, maybe like postpartum day 3 going forward, I would start to think maybe more of like a urinary tract infection. Later on, once we get a little further out, maybe around a week, I start to be concerned about a wound infection, either a superficial wound infection or a surgical site infection. Going forward after that, I believe I forgot to say it initially, but it's walking, so that makes me start to be concerned about like a venous thrombotic event, so a DVT. Which could happen in the immediate postpartum period or immediate postoperative period, but also going forward. And then, of course, lastly, I would not want to exclude medication-related fever or additionally for a postpartum population, mastitis. But that being said, really, truly, any of these infectious sources could occur at any time. So I would want to be very diligent in obtaining a thorough history as well as a detailed physical exam.
So when you have a patient who is status post C-section, obviously her uterus is going to be tender just from the surgery itself. How would you make a diagnosis of endometritis?
Great. So once again, I would want to do a detailed history physical exam. Things that would lead me to suspect endometritis specifically would be pain that I felt was disproportionate to what I'd expect for this point postpartum. either complaints of pain or fundal tenderness on my clinical exam. Additionally, if I
Well, how
felt
would you said disproportional. I mean, everybody has a different pain threshold. So how would you make that subjective judgment?
right, and you're right. Unfortunately, it is somewhat subjective, but I would ask about medications the patient's tried, how often that she's been using her medication, assess if she has tenderness in other parts of her abdomen, any other sources of discomfort, and then as well in my physical exam. But you are right, there is definitely an element of some subjectivity in assessing this.
Um, so in your experience, how many days postpartum or post-op from a C-section, if that's the case, does it take for endometritis typically to show up?
Well, it can be diagnosed in the immediate postpartum period, but generally, I found that it sort of tends to present itself a little bit more clearly in the several days following delivery. So generally, in the first like week, I'd say you would start to have symptoms. You could potentially start to have symptoms of it.
Okay. Um, so, all right. What antibiotics did you use?
For this patient, I believe we used, if I recall correctly, I believe we used Unison. And the reason why we used Unison for this particular patient was that she wanted to have less frequent medication administration. So with Unison, I believe it's every 6 hours, and it's one agent. But one could also use ampicillin, gentamicin, and clindamycin, triple antibiotics, which we commonly use.
Why did you want to have administration less frequently?
I, I'm not 100% sure of her reasons, but she wanted to receive as few medications as possible. She also was pumping. She was kind of very annoyed by being in the hospital. She was annoyed by having the nurses come and bother her. She was trying to sleep, so she requested to have as infrequent medication administrations as possible.
Um, okay, last question. So, what are risk factors for uh, patient developing endometritis?
So one risk factor would be chorioamnionitis. Um, Other risk factors are things that would increase your risk would be, insufficient surgical prep or
I'm sorry, say it again. I didn't
inappropriate
hear you.
inappropriate surgical prep. So, for example, in the case of an emergent section, if the patient wasn't prepped as thoroughly as one typically would, an inappropriate administration of antibiotics if she didn't receive her antibiotics, within 1 hour of skin incision, or if it wasn't dosed appropriately. Um, so, for example, like an obese patient, if she weighed over 120 kilograms and didn't get 3 grams of ceftriaxone, that could potentially increase her risk. Other things are things that would in general increase your risk of infection. So obesity, diabetes, any sort of condition that would cause like a immunosuppression, so chronic steroid use, etc. Um, Presumably history of prior endometritis as well, potentially could increase your risk.
Why
Uh,
would that increase your risk?
Actually, that is a good question. I take that back.
Okay. Anything else you want to say about this?
In terms of increasing your risk of endometritis,
Just in general about anything I've asked you.
um, no, not. I'm not sure what I've left out.
Okay. Very good. Thought you did a nice job. So let's talk about it. And by the way, if anybody has any questions, as you know, I usually stop around 9:20, open it up for questions. And if nobody has any questions at that point about any of the cases, then certainly we'll pick another topic and another candidate. So wind, water, walk, wound, wonder drugs. So usually the walk part, so the DVT 3 to 5 days, can be as long as 7. And as you said, it could also be immediately post-op. Endometritis, certainly can show up a week later or even later than that. But typically patients show up, if they have endometritis, and again, this is a subjective diagnosis often, we think of it more a day or two after surgery. It's more common. It's unusual for somebody to come back and be admitted with endometritis. I'm not saying it never happens, of course, it does happen. But things to consider if it were to happen would include things like retained products of conception certainly would predispose somebody for I'll call it a delayed endometritis, if you will. So I thought you did a nice job with everything else you said. I think your risk factors were good. A couple others, again, prolonged rupture, and you said chorio, so that they usually almost go hand in hand when they occur. Smoking would be another, and again, retained products of conception. But other than that, I think you did and trust me, you gave me plenty of risk factors. I'm just filling it in because if one extra one sticks, great, and if it doesn't, you were fine with what you said. So I think that's it. Do you have any questions?
Yeah, so in terms of the antibiotic choice, to be completely honest, it was started before I came on, and I confirmed that it was an appropriate antibiotic regimen. And this particular patient was very angry to be in the hospital and didn't want to be bothered. Is that an appropriate enough excuse? Like, she truly did not want us to be bothering her at all.
Yeah, I didn't love that answer. I mean, it is what it is.
Okay.
But it's not quite the same as talking about insurance or any of those other kinds of things. But and you're not bad mouthing the patient. You're just giving a fact. But to the extent we didn't need to do that would be my preference from a technique, just from a technique standpoint.
Okay.
Then it's like, even though it's one patient, and I'm sure you don't. In fact, I know I've had you in the hot seat before. I've never heard you complain about your patients, but then it's like, Jesus, is she a whiner? She complain about all her patients that are, a little difficult or whatever. Right. So, anything you could do to tone that down a little bit. Patient had been started on this, in the emergency room or whatever.
Okay.
Or we selected an antibiotic that would require less dosing as the patient was extremely fatigued and really requested less antibiotic administration, which is what you said, but trying to take some of the patient was a pain in the ass out of it.
That makes sense. Okay.
And that's not what you said, but that was what was conjuring up in my mind when you were talking about her.
That makes sense.
Okay.
Great. All right. Thank you so much.
Thank you. Excuse me. Let's see. Dr. Yoon, trying to get you off mute.
Hello?
There you go. Hi, how are you?
I'm good.
Let me see if we can get your case list real quick. And you're a generalist, if I recall, right?
That's correct. Am I supposed to be able to see your screen, Dr. Green?
No, I haven't actually shared it yet, to be honest with you.
That's fine.
With these cases, with these I don't usually do it, but to be honest with you, it's been so long since I've had gotten to do a case list webinar instead of the structured cases. I'm happy to pull it up and show it to you and everybody else. So just give me a second, please. All right. So there you go. All right. This looks familiar, but patient number 3, I think we did. You and I have discussed patient 3 before, haven't we?
Yeah, with the cerclage, yes.
Yeah, okay. I'm going to give you another one just to. Patient number 6. Mm-hmm. So for those of you who can't see it, 30-year-old G2P0, 36 and 6. History of neonatal demise. She has intrahepatic cholestasis of pregnancy. She's an A2 diabetic. History of C-section. She had decelerations on antenatal testing, and she's a GBS carrier. Repeat C-section, glucose monitoring, MFM consult, steroids, and antibiotics. 19-day length of stay for mom, 3250, and 9 and 9 were the APGARs. So what gestational age was she actually admitted?
So she was admitted, so 19 days before, so that would be about 33, 34 weeks.
Okay. Okay, so she delivered at 36 and 6, is that correct?
Correct. That's correct, yeah.
Okay, so what caused you to admit her at, let's say, so 30, yeah, sorry.
Yeah, yeah, no problem. So she was getting antenatal testing, and she had fetal T cells on her antenatal testing, which prompted her to come to labor and delivery from the office.
So she was had antenatal testing. Was that because of the neonatal demise, or was that the A2 diabetes, or both?
It was both. It was A2 diabetes, the neonatal demise, and then yeah, for those two.
Okay, so do you recall what gestational age in her first pregnancy she had the neonatal demise?
Yeah, around 35 weeks.
Okay, so how did you adjust your what antenatal surveillance did you do, and when did you start it?
So with this patient, we started antenatal testing around a week before the patient had the demise, so around 34 weeks. And we did it twice a week, so once NST, once BPP, and then we did it like I said, once a week, and then also ultrasounds every 3 to 4 weeks for growth.
So in a typical A2 diabetic, do you do any increased antenatal surveillance?
We do, yes. For our GDMA2s, we do antenatal testing starting, depending on how their insulin sugar control is, around 32 to 34 weeks.
So you would have been doing antenatal testing on this patient anyway.
Correct.
And you didn't start any earlier, given the fact that she's an A2 diabetic and had the history of the neonatal demise?
No, that was a shared decision making between us, providers and the patient. And so she decided that she was comfortable with 34 weeks and she had good control over gestational diabetes. So we decided at 34 weeks.
So with respect to the cholestasis of pregnancy, what gestational age did that develop?
That developed around 35 weeks while she was in hospital. That's what she was diagnosed with that in the hospital stay.
Okay, when you have a patient with cholestasis, when would you normally induce that patient?
So that will depend on their bile acids level. So if their bile acids greater than 100, then you can consider induction at 36 weeks. If their bile acids less than 100, then you can consider induction at 36 to 39 weeks. In our office, we kind of do it like a gradient. So if their bile acids less than 40, but greater than 10, we do 39 weeks. If their bile acids from 40 to 60, then we do 38 weeks, and then kind of depending on what their levels are.
Why do you use the cutoffs that you use?
Because they've shown that bile acids greater than 100 really significantly increase your risk of IUFD versus less than 100. The risks are can be confounded by other factors like iatrogenic induction. So I believe the 100 is the cutoff where the IUD percentage is higher.
So why did this lady have her repeat section at 36 and 6?
So she had the repeat C-section at that time because when she was doing when she was inpatient and antenatal testing, she had a non-reassuring fetal testing, meaning like her NST was she had like a bradycardia that led to more of an emergency C-section.
So she got antibiotics. Were these just routine prophylactic antibiotics?
Yes, these were routine prophylactic antibiotics for her repeat C-section.
And what about the steroids? When were those administered?
So she was given antenatal steroids at 34 weeks when she came in for her fetal D cells from the office for possible, preterm delivery, just in case she needed to be delivered earlier.
Okay. Last question. What is thought to be the mechanism or the effects of the bile acids? I mean, why does it potentially create a poor outcome?
It can create arrhythmias, and so it can cause fetal demise, sudden fetal demise by the increased bile acids causing the heart to have arrhythmias.
Okay. Very nice job. So where did you guys adopt this protocol about the gradient for this is off the record now.
Yeah.
Question.
We have our own MFM group, and I believe they did it through SMFM, but I can't really quote you on that. They just it's just like a recent change that they've made in the last a year or so. So I'm not sure exactly where the source is from.
Okay. So I thought you did a really great job. The only comment I would make is I would be a little bit more specific about the A2 monitoring. So you said you did it 32 to 34 weeks. So I don't really have a major problem with that, but I guess where I'm coming from, I think I would be a little bit more proactive in saying that the group recommended the patient start monitoring at 32 weeks. I mean, and the reason I say that is if you normally monitor an A2 between 32 and 34, depending on the glycemic control, and I get the 34 if she's well controlled, and in isolation, that would make sense for this patient. But given the fact that she had a history of a neonatal demise and it was at 35 weeks, again, you're fine starting it if that were the only risk factor, starting it at 34 weeks would be, reasonable.
Right.
But when you put the two things together, that would prompt me to start go on the early side of the A2, or if, screening somebody that had a history of a neonatal demise, 2 or 3 weeks earlier instead of 1 week. That would push me to being that much more cautious. Does that make sense?
Yeah, just a little bit more aggressive in that because she has more than 2 risk factors.
Well, she's got 2 risk factors, and when you put them together, it's like, geez, if one of them says 32 to 34 in isolation, add that other one in, I'm going to at least recommend 32. She may, still decided on 34, but I would be a little bit more proactive in my explanation if I were asked this on the boards.
Gotcha. Okay. Thank you.
And again, you didn't do anything wrong, but it's what I would say. So in terms of the cholestasis of pregnancy, and I can't remember, it's probably 2 or 3 years ago, and I don't remember if it was an MOC article, but there was a study done I think it was in England, but it was on somewhere on that big island over there. It might have been Scotland, I don't recall. But anyway, they looked at delaying delivery and fetal outcome. The long and the short of it was they actually did use a cutoff, or what they found was patients with bile acids greater than 100 had significant and serious risk to the baby. Less than 100, the events occurred with much less frequency. So they were actually even advocating for prolongation, even I think it was, and again, don't quote me on this, but it was roughly up to 38 weeks. Again, if the bile acids were less than 100. However, the stuff I've even read most recently here still stuck at that 36 to 37. And certainly if you have bile acids above 40, I'm not obviously debating with your MFM or saying they're wrong, but this is the most recent stuff that I've read, again, more locally. The other thing was was a study, but not a absolute, formal recommendation from ACOG or SFM. So, again, I think you could say that, that your MFMs, recommend this gradient, and, you've had good success with it or whatever.
Okay.
But I mean, for the rest of the folks on the call, I probably would stick more to the 36, 37 again, unless you have some sort of specific setup in your hospital, just because I haven't seen it as an accepted, hey, we now recommend X, Y, and Z.
Yeah, I can put.
Okay.
Sounds good.
Great job. Thank you.
Mm-hmm.
Okay. So, give me a second here, folks. Rebecca, I'm trying to get you off mute next. Hey,
Can you hear me?
Rebecca.
Hi.
I can hear you now. How are you?
Good, how are you?
Doing well, thanks. Are you a generalist or specialist?
I'm a generalist.
Okay. And you sent your list in, I assume, right?
Yes, I think it actually may be under my maiden name, which is Maydell, M-A-D-E-L-L.
M-A-D-E-L.
I'm not sure why it went under that.
I'm sorry, did you say Maydell?
Yep, it's that one.
M-A-D. Okay. I was like, wow, we'd have a Maydell and a Mazel. That'd be kind of unusual. Okie doke. Let's see what we got here. So, okay. Patient number 8 is a 22-year-old G3P2, initial OB visit, possible fetal anatomy. I'm sorry, possible fetal anatomy noted on ultrasound. Possible fetal anomaly noted on ultrasound in emergency room. The ultrasound showed gastroschisis, but no other abnormalities. The AFP tetra was positive for open spina bifida. The initial obstetrical labs were positive for chlamydia. The NIPT was negative. We had counseling regarding gastroschisis, chlamydia treatment and need for partner treatment, safe sex counseling, transfer care to MFM, and she had ongoing prenatal care at the tertiary care center. All right, so first of all, as for this patient, which abdominal wall defect is associated with chromosomal abnormalities?
The omphalocele.
Okay. In terms of mode of delivery, what would you counsel a patient who has gastroschisis?
So gastroschisis in general is not a contraindication for vaginal delivery. The omphalocele would be, which is kind of a difference between the gastroschisis and the omphalocele. Depending on how much of the abdominal contents were, herniated outside of the abdomen, it may be recommended by MFM to do a cesarean section versus a vaginal delivery. But gastroschisis in itself would not be a complete contraindication to vaginal delivery.
So do you know what ended up happening with this patient?
I actually do not. She presented towards the end of my case list kind of gathering. And so she may actually, she's probably not, she probably just delivered.
Okay. Just as an FYI, guys, and this doesn't just apply to you, Rebecca, this is for everybody. So if it's possible when you send the patient to a consultant, like it really comes up with GYN oncology, if you can have a high level, understanding, hey, she delivered a term, pediatric surgery, corrected the anomaly and the baby's doing well, something high level. Or if it's an oncology patient, the patient ended up having stage 2B endometrial cancer. She had surgery and, she's getting chemoradiation or whatever, and her prognosis is X.
Okay.
So
I
again,
may or may
we'll need
not
to
be able to get that information just because we actually send them we have to send them about an hour away to a university center, but I will try to get that information for her.
Again, I wouldn't spend a day doing it, but to the extent that you can, it's nice because what it shows the examiner is, hey, she's compassionate, she cares about her patients, and that kind of stuff.
Right. Right.
But if you can't, it's not the end of the world. Anyway, all right. So back to our story. So this patient had chlamydia. You have need for partner treatment. I assume you treated this patient. Is that right?
I did treat her, yes.
Okay. And when would you do follow-up for the chlamydia?
So I would recommend that her partner gets treated. I would recommend that they do not have sex within 7 days of both getting treated. And then I would test for a test of cure at the end of 14 days.
14 days after you treat her?
Yes.
Okay. So when you have a patient that comes in for, let's say, a preconception evaluation, obviously you're doing a history and physical. Let's assume that she has no medical problems. What tests would you do and what counseling would you provide her?
For this patient or in general?
In general.
So depending on their age and their family history, I would recommend, that they start taking prenatal vitamins as the highest kind of bang for your buck there is going to be within the first 6 weeks before you get pregnant. In terms of family history and genetic history, if they have any history of genetic disorders, then I may consider doing a panel for genetic testing. I would test for cystic fibrosis, and depending on their family history, if they have a history of, if they're an Ashkenazi Jew, they would be at increased risk for the lysosomal storage disorders, and so I would test for those. I think those would be the two big ones. Oh, as well as any type of, if they're African American, maybe sickle cell disease or other thalassemias, if they're of Mediterranean descent.
So you said you're going to start her on a prenatal vitamin. Why does she need a prenatal vitamin as compared to, let's just say, a regular multivitamin?
So the prenatal vitamin has the extra folic acid, and that is going to be the biggest concern in the 6 weeks before getting pregnant, to prevent the open neural tube defects.
So you said it's going to have extra folic acid. How much folic acid is in a prenatal vitamin?
It should be 4 micrograms.
4 micrograms?
Yes.
Are you sure?
Yes.
How much, if the patient was on an anti-seizure medication, how much folic acid would she need then?
I believe that would be 4 milligrams. 4 milligrams.
All right, so 4 micrograms and 4 milligrams. Okay. If the patient had a history of, again, neural tube defect affected infant, you said 4 milligrams. How long in advance of conception should she be on that?
6 weeks.
Okay. And so are you saying that regular multivitamins don't have at least 4 micrograms of folic acid?
I am not sure about that.
Okay. Is there anything else that might be in the prenatal vitamin that's not in the regular multivitamin or vice versa that you would be concerned about?
The other thing that is in a prenatal vitamin is generally iron, and we would definitely want to have a hemoglobin that is appropriate for pregnancy and have the patient not be anemic as well.
Okay. And again, anything that one or the other, well, you said the iron. Okay. So if the patient were a pre-gestational diabetic, would she also require 4 micrograms, or would she require a different dose?
I believe diabetics still require the normal dose.
Okay. And then now you mentioned, what about vaccinations? Do you ever check on immune status for these folks?
I definitely would check on the immune status of rubella, just because that's one of the vaccinations that you cannot give in pregnancy. And so if she was rubella non-immune, I would give her the MMR vaccine at least 6 weeks before trying to become pregnant.
All right, so she should wait for 6 weeks, right?
Yes.
Anything else other than varicella? There you go. Hey, there's your answer. Would you have
Yes,
to wait?
varicella as well, because that's another live vaccine that you cannot give in pregnancy.
6 weeks again? Should she wait 6 weeks?
I'm not sure about the time period between giving the varicella vaccine and getting pregnant.
Okay. You mentioned Ashkenazi Jewish patients with storage disease. Can you tell me specifically what tests you would recommend for a patient of Ashkenazi Jewish descent?
I definitely would, like I said, recommend the panel for all of the lysosomal storage diseases as well as cystic fibrosis.
Which lysosomal storage diseases?
I know, I'm not sure if I'm saying this right, Gaucher's disease. Oh my goodness. I'm blanking on the rest of them. There are quite a few.
All right. Any other tests you would do on an Ashkenazi Jewish patient?
I'm sure there are.
Okay. All right. Let's talk about this one. So certainly it can, not that the case devolved, but certainly it's under the category of preconceptual counseling. They can certainly do a 180 on you and basically just make up a case that fits under the topic, which is what I did for you after asking a few questions. So basically for rubella and varicella, which you would want to check their immune status, either verbally or preferably if they have a known history of having the shot or the infection. If there's any uncertainty, you can certainly do a titer. But you'd want her to wait for 4 weeks after receiving the vaccine before attempting to get pregnant. There's never been a reported case. If she were to get pregnant sooner, say in a couple, 3 weeks, you would still counsel her that it's a theoretical risk, and there's never been shown to be a case of congenital rubella or varicella from getting pregnant too soon after a vaccine.
Right.
In terms of the prenatal versus multivitamin, so you said 4 micrograms. It's 400 micrograms or 0.4 milligrams.
Yes.
So most prenatal vitamins are going to have most prenatal vitamins that are prescription are going to have 1 milligram of folic acid, and that's why you need the prescription. Most regular multivitamins have 800 micrograms of folic acid, so really they have enough folic acid.
Right.
What they may be missing is the iron, as you mentioned, DHA potentially, and the real problem, more than those two components, the real problem is they have too much vitamin A, which, as we know, is fat soluble and can accumulate and cause adverse effects for the baby. So that's the real reason why we go with a prenatal. Again, they have little or no vitamin A. Okay, so in terms of diabetes, so actually diabetics should have 800 micrograms of folic acid if they're pregestational diabetic.
800.
And so 800. And
800.
for the low risk patient that's on 400, they should ideally have the folic acid. You said 6 weeks, a month is adequate. But really, as you know, we tell everybody who's reproductive age to be on folic acid just in case anyway. For somebody who's on 4 milligrams, like the patient with either the seizure history on seizure medications, or had an affected child, or she herself had a neural tube defect, we recommend the 4 milligrams, as you said. And those folks should actually be on it for 90 days at least before they conceive. In terms of the Ashkenazi Jewish patient, and the reason I ask about this, oh, by the way, before we go there, I just want to mention about the chlamydia. So chlamydia tests a cure or in pregnancy, typically not sooner than 3 weeks is what's recommended. So just might want to modify that slightly. So the reason I asked about the Ashkenazi Jewish patients, there was a practice bulletin that was specifically geared toward Ashkenazi Jewish patients. I haven't seen it that it was replaced, and it may well have been replaced, not for specifically Jewish patients, but for screening. But in any case, the tests in that bulletin, there are other tests that have been added since that came out, but there were 4 tests that were recommended. And that would be cystic fibrosis, Tay-Sachs disease, familial dysautonomia, and Canavan's disease. And then there were 5 others that you could offer, excuse me, which included Gaucher's disease, Niemann-Pick, mucolipidosis type 4, Fanconi's anemia, and Bloom syndrome. Do you have any idea of the 9 tests I just listed, which one has the highest incidence carrier rate?
Tay-Sachs?
Actually, it's Gaucher's.
Oh, I should have said that. Actually, my sister got tested for it and was a carrier. That was why it popped into my head.
So why do you think Gaucher's would be one of the ones that's recommended, but not, or should be offered, but not one of the 4 that you definitely should do? The reason behind that is because there's a treatment for Gaucher's disease. So whereas Tay-Sachs disease, for example, is fatal,
Right.
not the case for Gaucher's.
Okay.
So other things, spinal muscular atrophy would be another thing, for example, that's available since that bulletin came out a long time ago.
Okay.
Okay. Very good.
Thank you.
Sure. Okay. Paula?
Hello.
There you go. Hey, Paula, how are you?
I'm doing fine, thanks. How are you?
Good. Did your parents ever sing that song to you, Hey, Hey, Paula?
No, I don't know that one.
Oh, man, I'm showing my age. This is terrible. All right. What are the 17 causes of primary amenorrhea, since you're making me feel old? I'm kidding with you. Sorry. Seems funny in my mind. Okay, I don't see, I see your name listed here, but I don't see did you send in your list?
I did, yeah.
Huh. Says 0 items. Interesting. Let me see if they have, there's another one with your name. So I don't know why they're 2 separate ones. Are you a generalist or specialist?
I'm a generalist.
Okay, so let's see what we got here. All right, so patient number, sorry, I'll see it in a second. Patient number 6 is a 33-year-old nulliparous patient with an asymptomatic 15-centimeter adnexal mass in which endometrioma was suspected. She had a laparoscopic ovarian cystectomy which showed endometriosis. So what are some of the theories of spread of endometriosis?
The most common theory is the theory of retrograde menstruation, in which the menses sort of travels back through the fallopian tubes and into the abdomen, and then theoretically endometrial glands and stroma could implant into the abdomen and other various organs that way. There's also a thought that endometriosis could spread through the lymphovascular route. And then there's also sort of like the embryonic theories that some of the tissues in the abdomen, like the visceral peritoneum, are derived from the same embryonic origin, and so they can undergo metaplasia and become endometriosis under certain hormonal influences.
Okay. So when you have a patient that you suspect has endometriosis, well, this patient obviously did. So what treatment would you recommend for her for, let's say, maintenance treatment, given that she has endometriosis?
Yeah, so for a typical patient that undergoes resection of endometriosis or maybe like a cystectomy like she did, I do recommend that they go on oral contraceptive pills afterwards to suppress ovulation and prevent further endometriomas from developing.
Okay. So how might endometriosis appear in a teenager? Would the appearance potentially be different?
Possibly. Teenagers can still have cysts, so she could have presented, asymptomatically, or it could have been incidentally noted like it was in this case. Teenagers can have really painful menses. I think that's probably the most frequent presentation, but sometimes painful urination or painful bowel movements can be common as well.
Okay. What about, so do you ever use GnRH medications on patients that have endometriosis?
I do sometimes, yes.
Okay. And what would you use?
Yeah, if I'm going to use a GnRH agonist, I use Lupron, and I give the patient an IM dose. It's 11.25 milligrams every 3 months, anywhere from it's every 3 months, but I usually max out at 3 doses, sometimes 4.
So every 3 months. So what's the mechanism of action of Lupron?
Lupron is a GnRH agonist. It basically suppresses the hypothalamic pituitary axis and decreases the production of estrogen so that the endometriosis can regress.
Okay. What effect does it have on FSH?
I would expect the FSH to be high in a patient that is receiving Lupron.
The FSH to be high?
Yes.
Okay. Do you ever treat these patients if they're on, let's say, a year of Depo Lupron? Do you ever treat them with other medications?
Yes, so the patients that I put on Lupron, I generally recommend that they use add-back therapy, and that is to sort of decrease the chance of them having vasomotor symptoms along with the Lupron, and also hopefully minimize any bone loss that they might experience from prolonged use of the Lupron.
Okay, I'm sorry. What was the medication you said you'd use?
I just said add back, but usually I use 5 milligrams of agestin daily.
Okay. And again, you said for the bone protection, and also what else? What other benefit would it have?
To minimize vasomotor symptoms.
Okay. All right. You said you'd use it up to a year. I mean, can you continue using I mean, could you give her another course of Lupron in the future? Let's say you treated her with 4 doses. Could you ever use it again on her?
I think you could. There are other medications out there, though, that I would typically transition to. I don't advise using it for more than a year because it can lead to osteoporosis.
Okay. Give me 1 second. Okay, very nice. Let's talk about this one. So very nice job with the theories of spread of endometriosis. So we would be thinking, as you said, retrograde menstruation, lymphatic, hematologic is another thought. And then, of course, what you were talking about, the embryologic development. So that's more along the lines of like a coelomic metaplasia is the term I believe that's used for that.
Okay.
Adolescent patients, the endometriosis can appear differently from the powder burn spots that we're used to seeing in a little bit older patients. And there was actually, I don't know if it was a practice bulletin or if it was just an MOC article from probably 3 or 4 years ago, but it was describing how the appearance of the endometriosis lesions in younger patients, and they can be clear, they can be red, sometimes even yellow-brown, but they don't necessarily have that powder burn appearance. And certainly patients even, endometriosis has even been seen in adolescents, children, even as young as 8 years of age, albeit obviously that's unusual. But it is to keep in the back of your mind, certainly for patients with dysmenorrhea, even as young as 12, 13, 14 years old. It doesn't mean that's what they have, but it can show up in younger patients. So in terms of treatment, the Lupron, everything you said about that was good, except Lupron is going to cause a reduction actually in FSH.
Okay.
Initially, there'll be a flare when you give the shot of FSH, but ultimately it will become suppressed. So basically for FSH to be released, there needs to be a pulsatile secretion of GnRH. And when we give Lupron, what we're doing is we're basically flooding those receptors. So the level goes up, meaning the GnRH goes up, but it never comes back down. And it's the delta, if you will, that's needed for this to produce the FSH. So you get a spike or a flare for 2 weeks, and then it typically is suppressed. It's a little bit the opposite of what we think about, because you're right, the estrogen does go down. And you were also right about add-back therapy for the main reason is for bone protection. The secondary reason, of course, is obviously we want our patients to be as comfortable as possible. Typically a year, you can use it again over a period of time for a second year, but it is a little bit, some people would use it even longer, especially with add-back therapy. But I think for most of us that are generalists, if asked on the boards, I would go with the maximum of using it twice. When I say twice, I mean total of 2 years, but not consecutively.
Okay.
Any questions?
No, I think I just misunderstood your question about the adolescents. I was thinking like clinical presentation, not like visually on laparoscopy. So that's helpful. I'll keep that in mind about the.
Yeah, I probably could have been clearer with the question, so sorry about that.
But other than that, thank you for the questions.
Thank you. I'm going to put you back on mute. Thank you.
Thanks.
Okay, so guys, we are at 9:25, and some folks wrote some only I could get it to stay open here. Some people wrote in the question box, so I'm going to see if we can open this up a little bit. So thank you, guys. We had a couple folks write in for clarification regarding the bile acids. So bile acids greater than 100 recommendation is in the Delivery Timing Committee opinion. As Society of Fetal Medicine says, I'm going to keep you in suspense for a minute, that patients with total bile acids of 100 may be offered delivery at 36 weeks of gestation, given that the risk of stillbirth increases substantially around this gestational age. That's 1B, that's grade 1B evidence. We recommend delivery between 36 and 39 weeks of gestational age for patients with intrahepatic cholestasis of pregnancy and total bile acids less than 100. That's a 1C. Delivery timing for women with total bile acids less than 100 should be individualized. It is reasonable for patients with bile acids of less than 40 to be managed toward the later end of this time range, given the low risk of stillbirth seen in the studies referenced above, whereas women with total bile acid levels of 40 should be considered for earlier delivery. So that's that. Can we talk more about add-back therapy for Lupron was the other question, and I'll certainly open it to people to raise their hand after we answer this one. So yeah, the traditionally add-back therapy is recommended for patients that are on Lupron. Certainly, if you have the patient on beyond 6 months, you would want to provide add-back therapy. The classic is the agestin or norethindrone that Paula mentioned, and that's basically 5 milligrams a day. The primary goal for that is bone protection. However, we know progesterones, even in menopausal patients, will help to offset vasomotor symptoms. It's not quite as good as estrogen progesterone, but our estrogen therapy, but it is still effective. About 70% of patients that are on a progestational agent, for example, in menopause, would have improvement in their vasomotor symptoms. So there is some benefit from a symptomatic relief, even in patients who are on prolonged GnRH agonist therapy. So definitely beyond 6 months, again, you'd want to use add-back. There's been some movement whereby some people are putting patients on low-dose birth control pills. And so combination estrogen progesterone, which traditionally was not recommended, given the fact that, you know, it's like you're giving this patient estrogen. Well, you're giving her estrogen and progesterone, and you're suppressing them. Those folks actually had a better response, certainly for symptomatic relief, as compared to the progesterone alone, and the bone protection was also the same. So I'm not saying it's everybody does it, but it is something that has been, they've done a study on, and it appears to be not only safe, but effective for the patient. So hopefully that answers that question. All right, I put everybody's hand down, so if anybody has any questions, comments, anything they want to add to from the talk tonight, and thank you to the folks that put in the information about the updated bile acids. It's appreciated. So if anybody else has any comments or questions, please raise your hand, because I did put everybody's hand down. Going once, twice. Okay, I don't see anybody else's hand, and we are at 9:29, so I think we are going to wrap up for the evening. Hope you guys have a great rest of the week. I will look forward to speaking with you again. Let's see. I will look forward to speaking with you guys again on the 17th. So in the meantime, have a great rest of the week, and we'll talk to you all soon. Good night.